Welcome to the Food Junkies podcast. Here, we aim to provide you with the experience, strength, and hope of professionals actively working on the front lines in the field of food addiction. The purpose of our show is to educate you, the listener, and increase overall awareness about food addiction as a disease with abstinence as the solution. Here, we talk about all things recovery. Most importantly, how to thrive rather than just survive. So stay positive, make a change for yourself, tell others about your change, and hopefully the message will spread.
Hey there, Food Junkies listeners. Molly here. I'm so excited for this episode, mainly because it's a topic near and dear to my heart. Meet Dr. Kirby Reutter, a bilingual clinical psychologist and leading trauma specialist. Dr. Reutter currently contracts with the U.S. Department of Homeland Security to provide treatment services for individuals seeking political asylum. He is also the author of 3 books, including the DBT Skills Workbook for PTSD. In this episode, we cover Dr. Kirby Reutter educates us on what PTSD is, how dialectical behavioral therapy, DBT, can treat PTSD. We talk about addiction, trauma, and DBT, how mindfulness can be a very important piece to treating trauma, our signature question, and so much more. We are definitely having Dr. Reutter back. Welcome, Dr. Reutter.
All right, we're so happy to have Dr. Kirby Reutter here on the program today. Welcome.
Thank you so much. It's such an honor to be here.
Well, we thought it was a topic we really haven't covered a lot of PTSD, how it can affect addiction and what role it can play in healing in recovery. So can you tell us, kind of provide us with an overview of your experience and your expertise in treating PTSD? Kind of what is PTSD? Like start at the basics, if you don't mind.
No, I don't mind at all. I'm not sure I can cover the basics of PTSD in a few minutes. But let me just start off with just a really, really quick kind of intro into what goes on when someone's traumatized. So we've all probably heard of fight or flight. Most of us have probably also heard of freeze. But most people don't really know kind of the mechanisms that are going on behind those phenomena. So basically, just in really simple layman's terms, trauma affects everything in the brain and everything in the nervous system, which is everything. And the nervous system has 2 major branches. One branch we call sympathetic, which is kind of like the accelerator. The other branch is parasympathetic, which is like the brake. So I like to use a simple analogy when I talk about trauma and PTSD. If we're driving down the road and it's, for the most part, clear sailing, sometimes we brake, sometimes we accelerate, but that's just kind of part of the ride. But if all of a sudden, there's a truck that swerves right in front of us, now we have to make a split-second decision. Do we either accelerate or slam on the brakes, right? We need to do something with those pedals that we have. And then if we can accelerate or brake and we don't get in an accident, great. We're rattled, but we survived. But then we keep going in our drive and we resume this pattern of accelerate when necessary, but brake when necessary, but it's for the most part a smooth ride. Okay, so when we're going through life, it's the same thing. Our parasympathetic and sympathetic nervous systems, they gently oscillate back and accelerate, brake as necessary. But sometimes when we're presented with danger or crisis, we need to slam on the accelerator. That's when our sympathetic nervous system is hijacked, so to speak. And that's when we go into either fight or flight. So those seem like opposites, but they're not. They're actually very similar because they both require tons of adrenaline to mobilize us. And so if we can fight off something, well, great, we did it. We survived. If we know we can't fight, well, then we use that same energy to mobilize us to run, to bolt. Okay, but sometimes we can't do either response. And that's when freeze kicks in. So that's like slamming on the brakes. That's when we dissociate. That's when we check out. That's when we pass out. We faint. All kinds of things can happen. Now, the problem is, and sorry if I'm taking too long here, but this is where trauma comes in. Because what happens is we're still slamming on the accelerator. The adrenaline is still going through our system. And in addition, now we're slamming on the brake. That's what causes all kinds of issues internally. Because now the entire body and mind is kind of at war with itself. Because the more you step on the accelerator, the more you step on the brake, and you have this escalating civil war going on. So when people are able to fight or flee successfully, yes, they're rattled. Yes, it affects them. Yes, they kind of lose their balance a little bit, but they'll be fine for the most part. Why? Because all of that adrenaline was used. It was expended. And furthermore, you even leave that situation with a sense of resiliency. Like, wow, I survived. I was able to do this. But what happens is when you can't do either of those two, and now the freeze has to kick in, now the person feels helpless and stuck. Like, well, why didn't I do more? For example, in the case of rape, why didn't I resist? Well, the thing is, you couldn't. The paralysis effect was literally activated. And then that brings in all of this shame, all of this guilt, all of this humiliation that I couldn't do more. I didn't do what I should have done. But furthermore, those two mechanisms of fight, flight on one hand and freeze on the other hand stay stuck. So going back to the road analogy, it's sort of like barreling down the road, and now you're just randomly accelerating, randomly braking, sometimes doing both at the same time. So that in and of itself is going to cause problems on the road. And that's kind of what PTSD is. It's when both of those systems have been hijacked.
So how did you specifically get interested in working in this field and to become somebody who kind of wrote a textbook or a workbook on it?
Yeah, I guess the short answer to that is life. I grew up surrounded by PTSD. I married into PTSD. I had my own history of PTSD. So I just kind of had it from every angle possible. And so I didn't start off life as a psychologist. I didn't even start off adulthood as a psychologist. It's something I kind of just stumbled into. The more I did research for myself, I just dove into the self-help literature and I couldn't get enough. And the more I read and the more I learned, the more I realized, well, maybe I should just someday do this for a career because I kind of already know a lot about it.
Yeah, it makes a lot of sense. I mean, certainly Molly and I had our own food addiction story and addiction and mental health in the past, which made us really passionate about helping others when, we figured out what things might actually work for people. So I'm wondering why DBT speaks so much to working with PTSD for you.
Yeah, no, it's a great question. So, when I went to grad school, which, as you know, takes forever, I didn't know really anything about DBT until my internship. And I was very fortunate that I had an internship that was literally 2 semesters of DBT at a major research hospital up in Burlington, Vermont, through the University of Vermont. And so I was doing, literally probably 3 to 5 hours of DBT groups a day for 2 semesters. And so it was full immersion into DBT. That's how I learned the model inside and out. But the reason I fell in love with it, probably for a couple reasons. One was it was so practical because the whole model is skills that you can start to use immediately. So, whereas in grad school, I learned all of these models and all of these theories, which was great. It was lots of information, but I didn't know what to do with any of it. Whereas DBT showed me this is what you do. But even more importantly, the more I learned about DBT, the more I used it in my own personal life and the more I saw it worked. It worked for me. And so therefore, when I taught it to the participants in this partial hospitalization program that I was doing my internship for, the authenticity came through because I wasn't just teaching DBT, I was living it. And, I would walk into group and I would tell the participants that, oh yeah, this is a tough skill. I know that because this is a skill I'm working on myself. I didn't tell them that I was trying it out last night, but I was literally 1 page ahead of them in the manual. As I was learning it myself, I was then teaching it to them.
So speaking of DBT, and that falling in love with it, it's the skills-based theory, and I shouldn't even say theory, I mean practice, and realizing that it was so helpful. What have you found are really like the main principles of DBT that really work well when it comes to, because it was created, right? Like Marsha Linehan really developed it to treat her own self, right? And she was very suicidal, all of those, if I'm understanding her story correctly, and please, if I'm not, jump in there. So what is it about DBT, dialectical behavioral therapy? What is it about DBT and its principles that really spoke to you in treating PTSD or even CPTSD?
Yeah. So like I mentioned, DBT is a model of psychotherapy that it consists exclusively of skills work. And there's 5 specific modules in particular. So there's mindfulness, which is all about being aware and accepting of the moment. There's distress tolerance, which is all about coping with current situations in a way that doesn't make them even worse. There's emotion regulation, which is all about learning a healthier lifestyle that will support healthier emotions, healthier emotionality. And then there's also interpersonal effectiveness, which is obviously all about more effective ways of dealing with people. And then there's also this idea of dialectics or dialectical thinking, which is all about learning to bring together opposites and see things from new and fresh perspectives. So like you kind of hinted at, DBT was originally designed to treat symptoms of borderline personality disorder, which is a disorder of emotional dysregulation. And at the time, and actually still to this day, it was the only model that was really effective at treating some of those symptoms. And it's still the gold standard. But I think the reason that DBT really skyrocketed as a model is because those 5 basic skill sets, as it turns out, can be useful for treating just about anything. So if you think about it, is it only people with borderline that need to learn to be more mindful or tolerate their distress or regulate emotions or think more dialectically or need more effective people? No, of course. Those are things that all humans need. And so I have found DBT really helpful in treating both trauma, PTSD, and like you mentioned, complex PTSD. There's a lot more I could
Yeah, I think I'm just wondering, like, if we can get a little more specific, thinking about those modules and taking somebody through them, can you give us some examples of like tools or skills, right, that we would be learning as we're going through those modules with you as somebody with PTSD or CPTSD?
Yeah. So each of those modules has many, many different skills. So let me just say this for starters. I would say that, one of the reasons that DBT, in my opinion, is a really good fit for trauma work is because borderline personality disorder and complex or developmental trauma are very, very similar. We don't have an official diagnosis yet. So we use developmental PTSD or complex PTSD in the literature and amongst ourselves as providers. It's not an official diagnosis yet. It should be. But if it were, it would line up very, very closely with borderline. But why specifically can DBT be really effective for PTSD? Well, I think it boils down to this. So remember, I gave the example of brake and accelerator, sympathetic and parasympathetic nervous systems. So one is the accelerator, right? It's all about an excess of what already is. The other is the brake, which is all about let's stop everything. Okay, those are two polar opposites. Those are extreme responses, which are necessary when dealing with a trauma. The problem is once those two systems are hijacked and kind of become your own, now the default, everything in life is either too much or too little, right? That sets us up for what Marshall Linehan called a dialectical dilemma. We're constantly dealing with all of these polarities. And the thing is, life already has enough polarities, enough contradictions, but trauma creates even more. So in particular, someone that's been traumatized, they end up with overthinking and underthinking, both. So overthinking in terms of just obsessive, perseverative, rumination. They can't get something out of their mind. So in terms of PTSD, think of intrusive memories or flashbacks or nightmares. But also underthinking, not thinking enough. So impulsivity, recklessness. They end up with, how can you end up with both at the same? Well, it's because trauma sets you up for those polarities. And you can go on and on. So another way that someone that's traumatized has this end result of both too much and too little is with emotionality. So too many emotions all at once, emotional overwhelm on one hand, but then on the other hand, completely shutting down, becoming numb, feeling dead, lifeless. Well, how can you have both at once? Well, if you understand what's happening with trauma, that makes complete sense, right? Fight or flight would be all about lots of emotions all at once. Freeze would be shutting all that down. So once again, overthinking, underthinking, overfeeling, underfeeling, but then you also have overreacting and underreacting. Once again, overreacting coming from fight, flight, underreacting come from freeze. So you have both of those at once. You sometimes in the same situation, part of you is overreacting and part of you is just completely shutting down. The same thing with relationships. You learn to either become too needy and clingy on one hand, or just too distant and avoidant on the other hand, or too aggressive on one hand versus too passive on the other hand, or over-dependent on one hand versus under-dependent on the other hand. So once again, with relationships, you end up with all of these polarities. But then even with attention itself. So with PTSD in particular, people who've been traumatized, on one hand, learn to become very super alert. So we call that hypervigilance. But on the other hand, they dissociate. Well, how can you have both at once? Well, if you understand trauma, you understand of course that's going to happen. Okay, so here's my point so far. With trauma, we end up with all of these polarities. DBT is designed to find a middle path between those extremes. So what's the middle path between hypervigilance on one hand versus dissociation on the other hand? Well, that's mindfulness. Mindfulness is the right balance. What's the middle path between too much overwhelming emotionality versus just feeling completely numb? Well, emotion regulation. That's the middle path. What's the middle path between overthinking versus underthinking? Dialectical thinking. What's the middle path between being too aggressive versus being too passive? Well, interpersonal effectiveness. So point for point, each of the skill sets that Marshall Linehan created ends up being the middle path for all these polarities created by trauma. And what's amazing is Marshall Linehan created this model before we even understood all of the neuroscience behind what's going on with trauma.
It's so funny how that happens, right? We have our own personal experience, whether it's our actual personal experience or our personal experience like in clinic, right? Where we're like seeing clients and we're seeing this happen. And, and somebody once told us that it's something like we can see it in session or with our clients, and it takes something like 17 years for the research to catch up. I'm like, that's insane. So here's Marsha. She's going through her own thing. She's trying to save her own life, doesn't have the brain science literature at this point, is creating this. And she's found this middle path for all of this. And to go to module 1, when we think about mindfulness and this idea of dissociation. So as you're like describing this, I just want to like out myself here, right? So I am a mental health professional. I've been in the field for 19 years. I was literally just diagnosed with CPTSD last year, like a year ago, after being in therapy for decades, like treating anxiety, treating depression, whatever it might be, and finally getting the correct diagnosis and getting some treatment that in the past year has really changed my life. But as you're like saying these things and you're like, if you understand trauma, you know how somebody can be both like in this hyper response place and this hypo response place. And I'm like, yeah, like, how did I not see that? I lived it all my life. I'm 41. So I lived it for 40 years, right? Because I just got this. And so it is so amazing when you can start to find that middle way. And so I'm wondering, because I'm a huge dissociator, like that's like my default is the numb, the freeze, the whatever. And I find that a lot of our clients are too, which makes sense, right? Because we go to the food or some kind of substance to really just go to that numb place. Can you kind of talk a bit about like some of those mindfulness skills that would really help somebody who goes or defaults to that dissociative place?
So yeah, just to piggyback on a couple of things you said. So first of all, absolutely something that's really frustrating to me, especially now that I specialize in trauma, is that academia is literally decades behind where the field is. So what our grad students are learning now is stuff from like 30, 40 years ago, where the field has evolved so much further. And so everything I've learned has been through my own study and professional development, not from grad school. So another way that DBT provides a middle path that I think I forgot to mention is distress tolerance is also the middle path between overreacting versus underreacting. So point for point, all of the modules of DBT teach that middle path. So specifically so you asked about mindfulness and how we can use mindfulness to deal with dissociation. Yeah. So when I teach mindfulness to clients, I keep it very basic and very practical. So, and especially with trauma work, what you want to do is start off with teaching mindfulness of the physical body for a few reasons. One reason being our body is a mindfulness machine, right? Our 5 senses are in the body. All of our sensations, like, temperature and pressure and all of that, are in the body. And our body is the window to the outside world. So if we're not even mindful of the mindfulness machine, right, if we're not even mindful of the body, we're not going to be mindful of anything else. And another really important reason for teaching mindfulness of the physical body is because that's where the trauma is stuck. Trauma is something that affects the body, affects the nervous system. Even if the trauma itself, like chronic invalidation, even if it did not directly assault the body, it affects the nervous system, which affects the whole body. And so because the nervous system is out of whack, things will be out of whack in the body. And if you're not, and that manifests as all kinds of physical aches and pains and symptoms, which we ignore, in which case the trauma stays stuck. So it's super important to start off with mindfulness of the body. And you can do that in very simple ways. That could be as simple as So like what I like to tell clients is, 5 minutes a day, just look at something mindfully. So something that you like to look at, listen to something mindfully for 5 minutes of the day, approximately. Smell something mindfully, taste something mindfully, feel, touch something mindfully. If they can do 5 minutes of mindfulness practice with their 5 senses throughout the day, that's already 25 minutes of mindfulness practice built into the day. So what I don't necessarily tell clients, and this is probably different than some of the conventional way of doing mindfulness, I don't tell them block 30 minutes out of your day and just focus on breathing or something like that. That's fine. I have nothing against that whatsoever. But for a lot of my clients, they're not going to do that. I want to make mindfulness something that they can latch onto and start to implement throughout the day, because that's where the rubber needs to hit the road anyway. So yeah, starting off with the 5 senses, but from there, you can also teach mindfulness of all kinds of different physical sensations and body movements, such as walk and dance and running. And all of that is designed to help them get in better touch with their own physical bodies, more attuned to their bodies, because the rest of trauma work isn't going to happen if they're not grounded in their own bodies.
Hey, Food Junkies listeners. We're just going to take a quick break here to share with you something our team thinks could help benefit your recovery with food, body, or self. Thank you again for listening.
Hey, Food Junkie listeners. Have you read the book Food Junkies: Recovery from Food Addiction yet? It all starts there. This is the book with the basic theory and clinical knowledge of food addiction. Read this book first to get the basics. Our Food Junkies podcast jumps off from the book and is the ongoing breathing version, ever growing and ever expanding. Our podcast introduces you to all the issues of food addiction and the who's who of food addiction today. And if we at the Food Junkies podcast have inspired you to action, either to quit sugar or some other triggering foods or behavior, and you need some extra support, then please join the free Facebook group I'm Sweet Enough, Sugar Free for Life. There you will find a community of people who come from all parts of the spectrum, from the new and just starting out, to the long-timers who call themselves food addicts in recovery, to counselors ready to give back and help you. The Facebook group even offers free support Zoom groups. Basically, it's a great online living resource of food addiction to help you stay sugar-free for life. So please join us.
Now back to the show. If you have enjoyed this episode, please let us know. We love to hear from you. Kindly leave us a review on whatever platform you listen to our podcast on. We love getting feedback from our listeners. So in your experience of working with PTSD and trauma, what is, you think, like kind of the correlation between addiction and PTSD, or having, those symptoms already prevalent, and then we maybe go to use a substance to cope with the PTSD or trauma we're experiencing? And then I just wondered if you could also speak to how is then treatment of that individual different from somebody with, just PTSD or CPTSD?
Yeah. So, when someone has complex trauma or borderline, you need to do lots of DBT type work just to stabilize first, because you don't want to do trauma work when someone is still in a active state of being very dysregulated, because that will just be further traumatizing. So that's where the DBT comes in, is to help clients stabilize to the point to learn enough of their own distress tolerance, self-soothing, self-regulation skills to the point where they can then do some deeper trauma work. So everyone's going to require some resourcing. So it's probably just more of a matter of degree. So specifically with the reason addictions can be highly correlated, well, there's probably many reasons, but some of the reasons that addictions can be highly correlated with trauma is, so like I've already mentioned, one of the symptoms of trauma is you just feel numb and dead, and nobody likes to feel numb and dead all the time. An addiction is one way to fill that void. It's a quick dopamine rush. Someone that has trauma also has lots of pain, both physical and psychological. And so an addiction can be a quick release or escape from that, for sure. But also, if you think about it, so like I already mentioned, someone that's been traumatized, not only are they hypo-responsive, I think that's a term you use, they're also hyper-responsive, they're overreactive. And so sometimes an addiction can help, quote unquote, bring some of that overstimulation down. So there's good reasons people end up with addictions. What basically the addiction is doing is helping putting out fires. It's doing lots of short-term heavy lifting on your behalf. But obviously the problem is that comes with lots of long-term collateral damage that you then have to reckon with. And so that's where DBT comes in particular, distress tolerance. Distress tolerance is all about learning more effective short-term reactions. And so distress tolerance from a DBT perspective is still reactive, but that's okay. You're learning different reactions. So basically coping skills in the moment to replace any behavior that's going to be impulsive or self-injurious or addictive or harmful to someone else, for the simple reason that all of those behaviors don't truly resolve crises. They only make them worse. Whereas distress tolerance, by definition, what it does is provide a different way of coping. Even if it doesn't solve the problem, at least you've coped better and you haven't made things even worse.
So could you give us an example of a distress tolerance skill that our listeners could use if they were, say, experiencing, a moment of whether it's a craving, right? Because that can feel very distressing to many individuals.
Yeah. So I already mentioned tuning into the five senses as a mindfulness exercise. And really all distress tolerance starts off with some kind of mindfulness practice. But once you get good at it, then you realize, oh, well, actually, this can be a coping tool as well. So certainly helping clients tap into their five senses, which is super practical because we always have the five senses on us at all times. So in particular, you would help a client identify, something that they can look at, something that they can listen to, taste, touch, etc. That has an immediate grounding effect, also immediate self-soothing effect. Another distress tolerance skill that I really like is called the TIP skill. It's an acronym, DBT, either fortunately or unfortunately, depending on your perspective, is loaded with acronyms. But I actually like the TIP acronym. It stands for temperature, intense exercise, paced breathing, and paired muscle relaxation. So the idea is, and with each of Marshall Linehan's acronyms, it's not just an acronym, it's also a metaphor. So the idea of the TIP skill, and it's actually a whole collection of skills, is since there's such an obvious mind-body connection, one of the quickest ways to shift your emotions is to tip your body chemistry, right? It's really hard to fight emotions with emotions, but if you can just change something in your body, a lot of times your emotions will follow suit really quickly. So you can do that by shifting your temperature. That's a skill I use all the time in my own personal life. All day long, I'm sipping something hot and something cold, so I can regulate. I use that to self-regulate all day long. And all I'm doing is shifting my body temperature. Intense physical activity doesn't mean go out and run a marathon necessarily, but just do something that will activate some of your internal body chemistry, like endorphins and dopamine, adrenaline, all that good stuff. And then, so we all know about diaphragmatic breathing, which obviously is very effective in and of itself. We also know about muscle relaxation, deliberately tensing a muscle versus and then relaxing it. But the TIP skill is all about combining those two. That's why it's called paced breathing and paired muscle relaxation. So as you inhale, you tighten your muscles. And as you exhale, you relax them. In fact, so you can do all four of those separately and they're all effective on their own. But the idea of TIP is the more of those you can do together. So if you can think of a single activity, so for me, it's riding my bicycle because that changes my temperature. It's an intense exercise. And then I just naturally fall into a breathing pattern. And I naturally have tensing, relaxing my muscles as I cycle. So for me, that's the perfect tip.
It's a great tool. We use that a lot with our clients too, as far as like, okay, you're in this responsive state, whatever it might be, or you're struggling in whatever way. And we take them through the same acronym and we love that tool so much. Thinking about, because often our clients, and I imagine you do too, I mean, statistically speaking, I feel like you probably run across this just as often as we do. There's often an overlap with severe mental illness and substance use disorder. I think it's something like 1 in 3 is the statistic. And so what I was wondering is, when you get that client who's in active substance use disorder, and maybe it's not quite progressed to substance use, like to meeting criteria, but there's active substance use going on, and you're trying to treat the trauma at the same time, how do you do that? Do you insist that the substance use stops before you can do the trauma work, or do you somehow combine it? Can you kind of walk us through how, like, that process?
Yeah. So obviously there's different thoughts on that in the field. And that thought process has evolved over time. So yeah, there was a time when people thought, they have to be absolutely clean of all substances and then we can do mental health. I think where the field is at now is, we can and should do both because they're so interrelated. So yeah, I don't have a set approach. So when it comes to addictions versus mental health, I try to work with whatever the client's goals are. So, if I'm using a strictly DBT perspective, what Marsha Linehan recommends is what's called dialectical abstinence, in which abstinence is the main goal. That's plan A. But that only works if that's the client's plan A as well, by the way. But if that's the client's goal and that's their stated plan A, then by all means, obviously I'm going to help support them. But then plan B is harm reduction in the event there's a relapse, with the goal then of getting back to plan A as soon as we can. So the acronym I like to use with clients, and this actually doesn't even come from DBT or Marsha Linehan, but I like to use the acronym SLIP. So if we're shooting for sobriety or abstinence or whatever that end goal is, but inevitably there's some kind of slip up, I like to frame the slip as skills learning in progress. Right? This was a good experience to have because now look at everything we've learned from it. And another simple analogy I like to use with clients, once again, assuming that sobriety, abstinence, recovery, substance abuse recovery is the goal, but there's that slip. I like to also frame it as a road trip. So in my case, this would be going from, let's say, Austin to Dallas. What's going to happen if I get off the wrong exit by accident? Because in any given road trip, I will do that. Well, I could say, well, screw this trip. I'm going back to where I started. I'm going back to Austin. Or I could say, oh, got off the wrong exit. Wonder how that happened. Okay, I better get on. I better get back on the right route. So what happens with addictions is when people do have that slip, what kicks in is that abstinence violation effect, in which, well, forget this, forget recovery. Why do I even try?
Yeah, we find the same thing. And I love your acronym because it's so true. It makes so much sense, right? Like the only time that I ask my clients not to be under the influence is like when we're in session. Like that's the only ask I have, because if you're coming to me and you're under the influence of the alcohol, of the whatever, we're not doing any work, like any true work. I mean, there are some crisis stuff that we can do, but we're not furthering any sort of goals, right? We're kind of in a holding pattern at that point. But yes, absolutely. Beyond that, I'm just like, what are your goals and how do we work toward them? And I love that acronym of SLIP because that is, and the driving, the road trip, I can so relate to that. I often use hiking. I think it's whatever is like the most prominent in our lives, right? That we like show up with this illustration of like, you wouldn't go all the way back to the trailhead. You would just go back to where you got off trail and get right back on, right? Like you don't have to like blow up the whole trip just because things went awry. It's like, oh, I wonder what happened there. Okay, go get back on track. So I just appreciate you taking us through that because it is a contentious point. We have colleagues who say, you have to be clean and sober for 2 years before you can ever address trauma. And as a clinician who's dual licensed for both, I'm like, that doesn't make sense to me. So now we have people sitting in their trauma response, just white knuckling it because as you explained, right, that oftentimes substance use or any of these behaviors, right, that we can form that addiction like behavior to, they serve a purpose. They create some sense of safety, if nothing else, because they're familiar. And so when we are constantly activated by the world around us, even when we're doing our best and we're practicing these skills, inevitably something is going to come along and activate us to a point where maybe we don't have the skill set yet to match whatever it is that's happening. So we might have like this recurrence of use or whatever it might be. And instead of going to that shame place, what I'm hearing you say is DBT says like, hey, let's just use a skill or what skill is needed and let's get right back on track. Am I understanding that correctly?
Yeah, absolutely. And you touched on a really important point. So people with histories of borderline, so obviously one of their impulsive addictive tendencies can be self-harm in different ways. What's really fascinating is, and it's going to sound so bizarre, but you don't want to take away someone's self-harm until you teach them some kind of replacement. Because historically, self-harm has been associated with suicidality. That's why it's in the same symptom in the DSM. But the thing is, they're different because you can be self-harming without be suicidal. You can also be suicidal without self-harming. They're two different things. And what we now know from the research is if you take away someone's self-harm without teaching replacement, you've actually just increased their suicidality, their potential for suicidality, because you've just removed the only coping skill they knew. And, to further speak to your point with substance abuse work, the more we can provide someone with mental health support and especially trauma recovery, the more we're helping them release the need for the addiction.
Oh, that's so great. I think that that's so important. And we definitely speak to that. We are harm reduction clinicians. And so that's exactly why we say, like, if you need to still be able to use some food from time to time, because that's where you're at in your recovery journey, and that makes sense to you, then we're not taking everything away, because like you said, they'll either be on plan or off plan, right? There's no middle that where exactly Dialectical lives. And so I think with this, it allows them to experiment. It allows them to see what actually works for them and feels good for them. And then they get to make their own mind up about what they want to do next. And that allows their goals to shift.
Yeah, and it's pretty fascinating that just a few weeks ago, I did a 3-day DBT training in Hawaii. It was awesome. And there was a passionate discussion on this very topic of abstinence versus harm reduction. And for the most part, the discussion was focusing on substances. But then someone asked, well, what about eating? Right? You can't just stop eating, right? So, it's one thing for a substance to say, well, the goal is to stop using a substance. But the point that this person was making is there's so many addictions in which that's so much more nuanced, such as eating. Like, the goal is stop eating? No, obviously not.
No, it's true. We run into this a lot because it's not that you stop eating, but you maybe stop eating foods that act like a substance for you, right? It's same with with alcohol, you don't stop drinking, right? You just stop drinking the substance. So, but yeah, it is so much more nuanced and so much more challenging to work with because of that. And that's where I think people need a little bit more time to practice. And it is so interesting with me always in recovery that there's still this belief in the field, like once you know you have a problem, you should just be able to quit the next day. Like you don't get to train, you don't get to practice, and then, if you don't figure it out, that's, back to day one, which kills my soul because we are very just individuals that really believe in having a compassionate approach to addiction recovery. And the recovery research says it's going to take some people around 7 or 8 years to even get 1 year full of abstinence. That is the trajectory for a lot of people. And so with having that knowledge, we have to be able to have the patience to support individuals along the way. And like you said, say okay, let's explore what happened there and get curious about it rather than, I can't believe I failed, right? Again, which I'll say first attempt at learning, right? First attempt in learning, or maybe it's your 50th attempt in learning, but we're always learning along the way. And that's still so important. So yeah, I absolutely appreciate that. I'm wondering if you can speak to some of the common misconceptions you run into about PTSD.
Yeah. So probably the biggest one out there is it's all in your head. So that's messaging that a lot of our clients have heard from others. It's messaging that they've given themselves. But unfortunately, it's also messaging that even exists. I want to be careful how I say this, but even in, I would say, the medical community. And what I would say is the medical community, this is so ironic, but the medical community as a whole doesn't seem to understand how much trauma affects the body physiologically and the brain physiologically. The medical community doesn't seem to grasp that yet. And so when you have the entire sympathetic and parasympathetic nervous system hijacked, not to mention, the amygdala and the hippocampus and so many things going on in the brain, that literally affects the body. Of course it does. It affects the body in many ways. But the problem is when these people go to the ER or go to a clinic or somewhere else, they're reporting so many different symptoms that don't fit the doctor's, nice little checklist because, the whole nervous system has been affected. So therefore there are too many things affected. So therefore, many times the medical community is likely to say something like, there's nothing wrong with you. I work at a clinic in which that happens all the time. I work with very highly traumatized people, many times actively in panic attack mode. They get checked out by a medical provider who said, runs their medical test, says there's nothing wrong with you. Then they get sent over to mental health. And the implication is it's in your head. And what I have to tell them is, no, there's a lot wrong right now. Of course you're in pain. Of course you're in pain in all of these places that you're telling me. And so the other thing that, which is, and hopefully I'm not coming across too strongly here, but that it just blows my mind that the medical community doesn't seem to understand is all pain is psychosomatic. All pain. If I hit you over the head with the hammer caused you no pain. It was your brain realizing, well, that was a very hard surface making cranial impact. I better send out some signals that suggest pain. But in the case of a hammer on your head, well, at least you can figure out, well, hammer, head, yeah, pain, that's where that's coming from, and it's localized. But when trauma hijacks your nervous system, that pain is not localized. And so all of this, dysregulation going on in your body, the brain doesn't know what to do with. So it sends out generalized pain signals, or it might send out literally pain signals for the wrong location, like phantom leg. So if someone's reporting pain, why not take it? It doesn't matter if you can figure it out physiologically or not. That is completely irrelevant. Yeah, so a lot of what I do with that misconception is I normalize, provide psychoeducation, and I validate.
Yeah, as you were saying, the medical community, maybe struggles a bit with this. And I've been thinking a lot about this lately, right? Because as a person who has an ACE score of above 6, like this chronic, right, or complex PTSD kind of story, and thinking about the gut-brain axis, and we think about things like chronic fatigue, like how that all kind of shows up, as you were saying, when you have these ACE scores that are 6 or higher, I think is what they're saying. It's like you literally have a life expectancy of 20 years less than somebody who doesn't have that score, right? And so that it's huge. It's huge that this is being missed, because often our medical doctors, our primary healthcare physicians, are like the first line of defense. Like, we're showing up to them saying like, oh gosh, I can't sleep well at night, or I have this weird, like you were saying, like this weird kind of like pain in my leg, or I can't keep food down, right? Whatever it might be. And so they run all these tests, and there's nothing like, I guess, conventional, we'll use the word conventional, right, wrong with somebody. It's not showing up on lab tests or whatever it might be. And you're right. Then they're referring them to mental health as if like, you're crazy, right? Is the implication. And so you need to go work with these other people. Meanwhile, hello, like it's all one, like it is one body. It's not like our head is disconnected from the rest of us, yet it gets treated that way. So speaking of all of that, then can we talk a little bit more before we move on? Can we flesh out just a little bit some of these other kind of manifestations, or I guess maybe pathways as to like how somebody could develop PTSD or CPTSD? You had mentioned earlier something about chronic invalidation, so even like having like those kind of experiences, or having, grown up in a household with like frightened or frightening parents. Like you said, maybe there was no like physical abuse, but there were other things that went on. So can you kind of talk a bit about other pathways to how we might develop symptoms or even meet criteria for PTSD? Yeah.
So since you specifically mentioned CPTSD, so let me just address that angle. So basically, I'll try to do this really quickly. There are 4 basic phases of brain development. And this is really important to understanding how developmental trauma manifests. So the first part of the brain to develop is the survival part. So right in the back of the brain. And so that's the part of the brain that does everything for us automatically. So circulation, digestion, respiration, etc., including fight, flight, freeze, right? That's all hardwired in. So if you're growing up in a healthy, nurturing, positive, affirming environment, whenever that survival brain gets triggered, you have an attachment figure, a caregiver, that can help co-regulate. So that part of the brain develops, but doesn't overdevelop. But what happens is if you're growing up in an environment in which it's not healthy and positive and affirming, that survival brain is constantly getting triggered. And the attachment figures, or the caregivers, maybe in quotes in both those terms, instead of helping co-regulate, they might be the ones actually actively triggering the survival brain. So that survival brain overdevelops, including fight, flight, freeze. And that's going to have a ripple effect moving forward on brain development. Because the next part of the brain to develop is the emotion brain. Now, if you have a stable, contained survival brain, that opens the way for a healthy variety, full range of emotions, both positive and negative, because you're going to need all of them later on in life, starting now. But what happens is if the survival brain is overdeveloped, that affects the emotion brain in 2 ways. One way is negative emotions will overdevelop. Why? Because you need them for fight, flight, freeze. And 2 in particular, fear and anger. You're going to need those to survive your environment. But positive emotions become underdeveloped. right? Because you don't really need them. And furthermore, right, if you feel like you just naturally love a caregiver who's abusing you, you learn that love's the bad thing. So you learn to shut down positive emotions. Those are no good. And that's going to continue to have a ripple effect, because the next part of the brain to develop is the attachment brain. And so if you have a well-contained, stable survival brain, you have the full range of emotions. Well, now you have the perfect ingredients for healthy, secure attachment. But if you have a survival brain that's constantly firing with fight, flight, freeze, and you only have fear and anger, well, you don't have much to work with to develop the attachment part of the brain. And furthermore, at this point in life, you've already learned that attachments are bad anyway. So that part of the brain doesn't develop. And then the final part of the brain to develop is the cognition, the thinking part of the brain, where we do our executive processing and all of that. So that's the part of the brain that we use to think about things like cause and effect, long-term versus short-term, pros and cons, like all of those dialectics. That's coming from this part of the brain. That's also the part of the brain that shapes our views about the self, the world, and others. Well, if everything else in brain development had been proceeding as it should, well, that part of the brain will also develop no problem, and you'll be a good decision maker. But if you have fight, flight, freeze, fear and anger, and not very good attachments, this part of the brain it's going to make life and death decisions. It's going to make decisions for the moment. It's not going to make you don't need to plan ahead for, where you want to get your master's degree when you're 5 years old and being beaten, right? You don't need to plan ahead. So the reason I went down that long tangent is because point for point, that describes developmental trauma. So what you end up with is overdeveloped survival brain, underdeveloped positive emotions, overdeveloped negative emotions, underdeveloped attachments, overdeveloped negative beliefs, because by the way, those negative beliefs are accurate for that person's world, and then underdeveloped decision making. I mean, point for point, that describes borderline, that describes developmental trauma. So PTSD, classic PTSD, is a little bit different in the sense that classic PTSD assumes you don't necessarily have any of that background in childhood. Your brain developed, the way it should, quote unquote, with resiliency. But then now, as an adult or as an adolescent, you experience something that's an outlier. And your brain, it's such an outlier that your brain doesn't even know how to internalize it. And then that's when you end up with all of these reenactment symptoms of flashbacks and intrusive memories and nightmares, because the brain literally doesn't even know what to do with this.
Yeah, it reminds me of years ago, I used to work I worked in a residential facility, and we were so used to the CPTSD type, track that people were experiencing. And we met this gentleman who had never touched a drop of alcohol till he was 27 years old. His child was hit and killed by a car right in front of him, like they were crossing the street or something along those lines, and picked up multiple DUIs in a matter of, months, just destroyed his life within a minimum of year, and it was just like you said, almost like that classic PTSD expression. And people couldn't figure out why he couldn't just get his life together. And it just reminds us all that, we don't know what's going on. You see somebody walking down the street, you really don't know what's going on. And just a good reminder too, again, for anybody in healthcare, that you can't just make these assumptions because it's not showing up on your test, that something else isn't actually going on. And that great reminder of again, it's not all in our head. I did want to ask a clarifying question about the emotion brain and the full range of emotions. We have experienced, and certainly this is not new phenomenon, I'm sure, but sometimes those quote unquote positive emotions can be just as dysregulating as quote unquote negative emotions for individuals. And so they're experiencing those positive things, and that can also then kind of be that activator to have a reoccurrence of use or some sort of behavioral, symptomology. Can you talk a bit about that at all?
Yeah. So, you're absolutely right. And so even to use the phraseology, positive emotions versus negative emotions is enormously problematic. I only use that because that's the language of the vernacular, and positive emotions meaning emotions that we kind of would rather have, negative emotions meaning emotions we would rather not have. So that was kind of my definition when I use those terms. But absolutely, the so-called positive emotions that we like, can be just as triggering, if not much more so. The classic example of that is bipolar. You don't worry about someone with bipolar so much when they're depressed. They're super motivated to get back on their meds, to do their treatment and to get out of that depressive episode. When they're manic, that's when you're concerned. So yeah, absolutely.
So I know we're getting close to the end of our time. I would love you to speak a little bit about your workbook that is the Dialectical Behavior Therapy Skills Workbook for PTSD. Who is it for? Should they be working with a therapist while going through it? What was kind of the process in creating it?
Yeah, sure. So the purpose of the workbook was basically to put in writing what I tend to do a lot with my clients. But it was also written to be completely self-help. So if someone wants to work through it completely on their own without external psychotherapy, that's a resource. But it's also a very good supplement or adjunct if they are in therapy. A lot of times it's helpful for the therapist to also be aware of the workbook and maybe even recommend specific chapters or exercises. The book is written sequentially, so each chapter kind of builds on previous material, but it's also possible to kind of jump around.
So where can our listeners find you?
Probably my website is probably the easiest way to find me.
And we'll link that in the show notes.
Okay, so before you go, we have a signature question for everybody. We tailor it for our guest. So we would love to know if you could tell a younger version of yourself something about PTSD, trauma in general, what would it be?
I would tell my younger self, I am so sorry that you had to go through all that. It was not your fault. You couldn't possibly have had the skills to deal with all of that. And I would have told my younger self that self-blame is in and of itself a symptom of trauma. So when you've been through something traumatizing that makes no sense, a lot of times our default is to make sense of it by blaming ourselves. Those burdens that you have carried for all of these years, you don't have to carry them anymore.
I love that. Thank you so much for that compassionate response and also for being with us today.
Thank you so much.
I've really enjoyed it. I fear I've talked way too much and monopolized, so I apologize for that.
No, you're the guest. You're supposed to. It's supposed to be about you. And we just thank you so much for sharing all your information and knowledge.
Yeah, thank you.
Thanks for joining us this week on Food Junkies, Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life support group, I'm Sweet Enough. You can subscribe to our show in iTunes or Stitchers. That way you'll never miss an episode. While you're at it, if you found value in this show, we'd appreciate a rating on iTunes. Or if you'd simply tell a friend about the show, that would help us out too. Don't forget to pick up your copy of Dr. Tarman's book, Food Junkies, which is available on Amazon. If you have any additional questions, both Molly and Clarissa are food addiction professionals and work one-on-one with clients. You can find their websites and email addresses in the show notes. Be sure to tune in every Friday when our new episodes drop. As Vera loves to say, the power is ours.